Proliferative diabetic retinopathy is an important indication for pars plana vitrectomy. The complex cases can be very challenging. To operate safely and efficiently on these eyes, a thorough knowledge of the pathoanatomy of PDR is essential. This enables the surgeon to make an accurate intraoperative assessment of the changes at the vitreoretinal interface, which can assume several configurations and achieve complete relief of traction on the retina with the least possible complications.
So
This short clip shows what looks like an apparently simple induction of posterior vitreous detachment in a case of PDR.
This sort of simple induction would be very uncommon. So
however, closer examination reveals another layer over the posterior pole, which is being removed after creating an edge. It is important to be aware of and suspect this second layer, and demonstration with high quality 3D animations can be an important educational tool towards this goal. The animation here depicts new vessels developing at the vitreoretinal interface and progressing to formation of fibrovascular sheets. At times, these sheets can extend very anteriorly and make surgery more challenging, as we will see in a subsequent video. This animation shows a highly magnified view of changes in the vitreous cortex after a bleed from new vessels.
So this sort of splits the vitreous cortex into an anterior and posterior leaf.
Splits the vitreous cortex into an anterior and posterior leaf, producing a vitreoschissus cavity. In a zoomed out view, we can see the adherent unsplit vitreous cortex with the adjacent schissus cavities. The fibrous element of the anterior leaf of vitreous cortex contracts, producing a traction retinal detachment. The posterior leaf of vitreous cortex remains attached to the retina. We now see this localized traction retinal detachment in the frontal view, and in its extreme form, this can produce a large tabletop traction retinal detachment. Centripetal contraction of the unsplit vitreous cortex can cause folds in the underlying retina. The single most important step in membrane surgery is to identify the posterior leaf of vitreous cortex, and if it is attached, create an edge and a flap of that before proceeding with dissection. This is a case of long-standing vitreous hemorrhage. The classical can opener appears to be through the posterior hyaloid face, but the subsequent wave of separation shows this second layer to be the posterior leaf of the vitreous cortex. This gives us the correct plane of dissection for removal of the adherent membrane over the posterior pole. In this case, we see an anterior extension of the membrane. It is important to separate the entire vitreous cortex peripheral to this. Here, this is being done with the 25 gauge vitreous cutter. The small gauge and controlled suction and cutting enable us to get into the correct plane, after which the dissection proceeds with relative ease. Here we see how easily one can start dissecting in the wrong plane.
This was the wrong plane which we were initially in.
Peripheral to the site of dissection, and the traction of the forceps lifting up the posterior leaf of vitreous cortex alerts us to this. Now we enter the correct plane, and the dissection is quick, precise and atraumatic. Scissors are used for blunt dissection where the attachments are fine, and cutting when a strong attachment is encountered. For bimanual dissection, forceps and scissors are most commonly used, but forceps cutter or cutter and scissors can also be employed. We generally prefer outside-in delamination, especially for the superior and lateral parts of the membrane, as this gives a better view of the connections between the membrane and retina, and consequently less bleeding and iatrogenic breaks. However, one needs to be flexible to do the best in a given situation. Apparently simpler looking cases can be extremely tricky and tough. In this case, despite repeated attempts, it was not possible to separate the hyaloid from the retina in the periphery. The posterior hyaloid face was then incised over an area of subhyaloid blood, and hyaloid separation extended around the disc and posterior pole with forceps and cutter. We could extend the separation radially in the lower nasal quadrant and then move circumferentially, superiorly and inferiorly peripheral to the fibrovascular membrane. When possible, we can segment the membrane to avoid too much traction on the retina during the separation. The posterior hyaloid was now separated temporally, and we can see parts of the membrane which were not very adherent also getting peeled off the retina. Finally, the superior extension was disconnected from the periphery and the rest of the membrane was delaminated bimanually. Surgery concluded with fluid air exchange, laser and C3F8 gas flush. In diabetic TRDs, gas and not oil is our preferred mode of tamponade.
Thank you for your attention.
Thank you, sir, for so beautiful animations and how to really teach. It's really wonderful. Thank you so much, sir.
I think it's always great to see Sir operate. We've been blessed to have him with us to mentor us. So I think hats off, sir. Very nice, sir.
Thank you. Thanks a lot.